I hope watching this last video is as bittersweet as it was making it. I tried to put in some more memes but had some technical difficulties, so instead your Pimpkin photos always brought me such great happiness, so I hope these other cute puppy pictures bring you some happiness in between watching my clips. Thank you so much, Dr. Pashun. The tests that you could perform to check the integrity of the collateral ligaments for the elbow are the varus and valgus stress tests. If you wanted to check the ulnar collateral ligament or medial collateral ligament, you would do a valgus test. The best position to test it is in about 20 degrees of elbow flexion. You're going to stabilize the humerus and provide valgus force into the forearm. Compare both sides. A positive test would be greater laxity on one side or reproduction of any medial pain. The collateral ligament test for the lateral collateral ligament would be a varus stress test. You would be in the same start position as the valgus stress test, stabilizing the distal humerus in about 20 degrees of elbow flexion. Then provide a varus force through the forearm. You're looking for reproduction of any radial-sided pain and or increased laxity compared to the uninvolved side, indicating a positive test. A test you can perform if you suspect a problem at the ulnar collateral ligament is called the milking maneuver test. Have the patient with their arm at 90 degrees of flexion. Their palm is up and you're going to stabilize at the elbow. Then come and pull their thumb and provide a little bit of valgus force like you're milking a cow. A positive test would be reproduction of the patient's complaints or increased laxity when comparing sides. Another test to stress the ulnar collateral ligament at the elbow is the moving valgus stress test. Bring the patient's arm to about 90 degrees of abduction and full elbow flexion. Then use your hand to provide some valgus stress right at the elbow. While you're giving the valgus stress, you're going to gradually straighten the elbow out. If you reproduce their pain somewhere between about 120 to 70 degrees of elbow flexion, that would be considered a positive test. There are 3 tests you could do if you suspect a lateral epicondylitis at the elbow. They're the Cozzens, Mills, and Maudsley's tests, and typically they're performed in that order. First, perform the Cozzens test. You're to instruct the patient to make a loose fist and have them pull their wrists up and tell them not to let you push them down. Essentially, you're performing resisted wrist extension. A positive test would be reproduction of their complaints. The next of the 3 you will perform is the Mills test, where you will put the extensors on stretch by straightening the elbow. Then flex the wrists and fingers. With that passive stretch, you are looking for reproduction of complaints that would be considered a positive test.
Passively up, and then she's in neutral, passively down, the stretch.
The last test of the series is the Maudsley's test. Have the patient relax their elbow, straighten out their fingers, and then perform resisted middle finger extension. Ensure you are distal to the PIP joint. If that elicits any pain or discomfort right at the tendon for the lateral epicondyle, that would also be a positive test. A test if you suspect a rupture of the biceps is called the bicep squeeze test. Have the patient rest their hand on their thigh somewhere between about 60 to 80 degrees of elbow flexion. Stand behind the patient and wrap your hands around right at their distal biceps. Then you're going to squeeze there. When you squeeze, you should see that there's a little bit of supination that happens at the forearm. If the biceps was not intact, you really wouldn't see probably any motion occurring at the forearm, and that would be considered a positive test. A test if you suspect ulnar nerve entrapment or pathology around the cubital tunnel is the elbow flexion test. Have the patient depress their shoulders, fully flex their elbows, supinate the forearms, and fully extend their wrists, pretty much like a server's position. Then instruct them to hold this position for 3 to 5 minutes. The test is positive if it reproduces any tingling, paresthesia, and the ulnar distribution of the forearm or hand during the time of testing. To further sensitize the test, you could also have your patient come into some shoulder abduction.
And the positive test would be the same.
test for suspected nerve irritation of the ulnar nerve at the cubital tunnel is the Tinel's test. Instruct the patient to be very relaxed. Then go right at the cubital tunnel and tap like you're trying to kind of tap on the funny bone. A positive test is if you reproduce the patient's specific complaints of pain. Most people will feel some kind of funny feeling, but you are looking for that patient's specific complaints. If you suspect a nerve involvement of the anterior interosseous nerve, you can do a tip-to-tip pinch grip or teardrop test. They're the same test, just various names for them. Instruct the patient to try to touch the tip of their thumb and the tip of their index finger together like you're making a big round O. Ensure the patient can hold that. If you see the patient begin to kind of go more tip to pad, and especially if they begin to lose what's happening at the IP joint of the thumb, that's considered a positive finding for a problem at the anterior interosseous nerve. The Watson or scaphoid shift test is used if you suspect carpal instability, especially at the scaphoid. First, you bring the patient into maximum ulnar deviation and slight extension. Then you will take your thumb and place it on the scaphoid on the palmar aspect and push, so basically pushing it dorsally. While you are pushing on the scaphoid, you will bring the patient into radial deviation and slight flexion. A positive finding is a clunk, as if the scaphoid wants to dislocate. Another test for assessing carpal instability is called the scapholunate shear test. The two troublesome areas would be the scapholunate region or the lunotriquetral region. For the scapholunate shear, you will palpate for the scaphoid and lunate. By sliding down the third metacarpal, and you'll drop right off to the capitate. Then from the capitate, move slightly ulnarly and proximally, and that will place you over the lunate. For the scaphoid, you can find it in the anatomical stuff box. You will now have both hands on the patient, one holding the lunate and the other holding the scaphoid. Then you'll perform a shearing motion between the two carpal bones. You are feeling for any hypermobility or reproduction of patient's complaints, and that would indicate a positive test. Remember to make sure you compare both sides. The lunotriquetral shear test is done in combination with the scapholunate shear test. You will first find the lunate like you did prior. By sliding down the third metacarpal, you'll drop right off to the capitate, and then from the capitate, move slightly ulnarly and proximally. Then you will palpate for the pisiform, which is sitting on top of the triquetrum. With one hand on the lunate and the other on the pisiform, you would perform a shearing motion between the two. You are feeling for any hypermobility or reproduction of the patient's complaints, and that would indicate a positive test. Again, make sure you compare both sides. The Lichtman test, or the mid-carpal shift test, is a different test you could do for suspected carpal instability, especially for a mid-carpal instability, which is instability between the proximal and distal row of the carpal bones. For this test, the patient should be sitting with their arm resting in some pronation. You will then palpate for the capitate and provide pressure on the dorsal aspect of it. Then you'll have the patient start in radial deviation, then axially load through the carpuses as you move the patient into ulnar deviation. A positive test would be if you feel the proximal row sublux towards you. Remember to compare both sides. The finger extension or shuck test is also used for suspected carpal instability. The patient will start in a resting position with their hand in slight wrist flexion and MCP flexion. You will then provide some resistance to the dorsal aspect of the fingers, just distal to the MCP joints, as the patient performs MCP extension. The test is considered positive if it reproduced any of the patient's complaints. The thumb CMC grind test is a test you can perform if the patient is complaining of radial-sided pain or pain at the base of the thumb. This test consists of two parts, the CMC axial load and the CMC grind test. For the load test, you would begin by stabilizing at the distal radius and carpal regions. Then take the first carpal, the thumb, and load right down into the joint. That would be the axial load part of the test. Then while you hold the CMC axial load and perform some circumduction of the metacarpal of the thumb, you might feel some crepitus or crunching, but a positive test would be reproduction of the patient's complaints. Remember to compare both sides. The distal radial ulnar joint stress test, or ballottement test, is used if you want to assess the joint integrity at the distal radial ulnar joint. You would begin by stabilizing the distal radius and hold on to the distal ulna. You would then perform shear motion in the anterior-posterior direction. A positive test would be reproduction of pain at the joint. Remember to compare both sides. The piano key test is another test you can perform to assess the joint integrity of the radial ulnar joint. You would begin by having the patient rest their forearm in slight pronation. You will then take your thumb and place it over the distal ulna and push down like a piano key, which will create a shearing motion between the distal radial ulnar joint. A positive test is reproduction of the patient's pain that is within the joint. Remember to compare both sides. The UCL stress test for the thumb is a test used if you suspect any ulnar collateral ligament injury. People also call this the gamekeeper or skier's thumb. You would begin by stabilizing the CMC joint in about 30 degrees of flexion. Then provide a stress to the ulnar collateral ligament. If you can produce pain or observe excessive motion beyond 30 degrees, that would be indicative of a possible partial tear of the UCL. Remember to compare both sides. The ulnomeniscal triquetral dorsal glide test is a test used for a suspected lesion of the triangular complex for the TFCC. You would begin by palpating for the pisiform on the palm side, which sits on top of the triquetrum, then placing your finger there. Then you would place your thumb on the dorsal aspect of the distal ulna. Then you will squeeze your fingers together to create a shear force or motion across the TFCC. A positive finding would be reproduction of the patient's pain on the ulnar side.
We didn't have a chair with armrest, so we have modified it with these two chairs.
The press sit to stand test is used to also assess TFCC. For this test, you will need a chair with arms. You will begin by having the patient rest their hand right on the armrest and instruct them to push through their hands like they are about to stand up from the chair. A positive test would be reproduction of the patient's pain on the ulnar side. The supination lift test is another test used to assess the TFCC. You will begin by having the patient sitting with both arms supinated on the table. You will then provide manual resistance at both wrists as they try to perform elbow flexion. However, clinically, you can have the patient place their forearms under the table and pull up as they are trying to lift the table. A positive test would be reproduction of the patient's pain on the ulnar aspect of the wrist. The ulnar impaction test and TFCC load test consists of two parts, and it is used if you are concerned about the TFCC. For the impaction part of this test, you are going to have the patient resting with their elbow flexed. You will then put them in ulnar deviation and then apply an axial load through the fourth and fifth metacarpals. You will be looking for reproduction of complaints in that position. In that position, you will then perform the load part of this test. You perform a scour motion by moving the patient into wrist flexion and extension while they are still in ulnar deviation. A positive test would be reproduction of the patient's complaints. The Bono-Littler test is used to try to determine if a person's limitations in their PIP motion is more due to intrinsic muscle tightness or the actual joint. To perform these tests, keep the MCP joint in kind of a relatively neutral position. and then passively see how much motion the patient has at their PIP joint. If they are limited, you wouldn't really know at that point if the limitation at the joint was due more to the joint capsule being tight or if it is the intrinsic muscle tightness. So then put the MCP joint into some flexion and reassess PIP joint motion. If the motion increased, you would then know that the problem that you were seeing originally was because the intrinsic muscles of the hand are tight. Versus if I put the MCP joint into flexion and I still have the same limitation that I originally had, that would mean the joint itself at the PIP is tight and limited. You can use the Haynes-Okole test to check the DIP joint and try to determine again if it's the joint itself or if it's the oblique retinacular ligaments that are tight. Have the patient's PIP joint in extension, and then passively see how much motion they have at the DIP joint. If it's limited, you don't know yet if it's coming from the joint itself or if it's coming from the retinacular ligaments. But then flex the PIP joint and reassess the DIP flexion. If DIP flexion increases in this position, then it would mean that the limitation you originally saw was due to the retinacular ligaments being tight. If you had the same amount of joint motion here as you did originally with the DIP, then that would mean that it was the joint capsule itself that is tight. If you have a concern that the patient may have De Quervain's problem, inflammation, or tenosynovitis of the first extensor compartment, then you can perform the Finkelstein test. Have the patient cover up their thumb with their fingers as shown. Then you are going to passively bring the patient into maximal ulnar deviation. If that reproduces pain right across the snuff box or in the first extensor compartment, that would be considered a positive finding. Two tests you can use to isolate and figure out if the problem is more the FDS or the FDP are the FDS and FDP tests. First, we will isolate out for FDS. Have the person rest with their hand out straight. The therapist will hold to keep the finger straight. Then instruct the patient to just bend one finger as you hold the other finger straight. By doing this, you know that the patient is not using FDP. It is relaxed. So you know that FDS is firing. You can perform this for all fingers. Now, to isolate out for FDP, have the patient perform flexion of the DIP joint. The therapist will block the finger everywhere else, like so. So you're only allowing the DIP joint to flex. Instruct the patient to go ahead and bend their finger. If the patient gets active flexion at the DIP joint, that signifies that the FDP is intact.
Yay.
If a patient is complaining of having difficulty straightening their fingers and you are concerned about the integrity of the extensor hood mechanism, you can perform the integrity of extensor hood test. Have the patient resting with their PIP joint supported, but they're at about 90 degrees of flexion, kind of having their fingers hanging and resting off the edge of a table as you can see. Apply very, very light resistance and ask the person to basically just extend their fingers out straight. You can do all fingers or one at a time. It is considered a positive test if the patient really can't provide any pressure or ability to extend against the therapist's resistance. A test you could do if you're concerned that your patient has carpal tunnel syndrome is the Phalen's test. Instruct the patient to put the backs of their hands together and then try to maximally bend their wrists as far as possible. Have the patient stay like this for up to 60 seconds. A positive test would be reproduction of any of the numbness, tingling, or pain that they may feel in the median nerve distribution while in this position. If your patient has the shoulder range of motion available, a test that you could do for carpal tunnel syndrome is a shoulder or arm elevation test, or a hand elevation test. Instruct the patient to elevate both arms as high as possible and then bend down at the wrist. Instruct the patient to stay there for up to 3 minutes. It is a positive test if it reproduces the patient's complaints of paresthesia or pain in the carpal tunnel or median nerve distribution. A test to assess the median nerve for possible carpal tunnel syndrome is a carpal compression test. Instruct the patient to rest with their forearms supinated. Then you're going to take both of your thumbs, kind of use the dummy thumb, and go right over where the median nerve would sit. Then apply compression there for up to 30 seconds and see if you reproduce the patient's complaints of median nerve irritation or paresthesia, indicating a positive test. A test you can perform if you are concerned about carpal tunnel syndrome is the reverse phalanx test. Instruct the patient to put the palms of their hands together and drop down into a prayer-type position at your chest so the patient gets maximum wrist extension. Instruct the patient to hold that for up to 60 seconds. It would be considered a positive test if you get reproductions of complaints of tingling, paresthesia, pain in the median nerve distribution. A test to assess the median nerve at the carpal tunnel that is very similar to a test that we did at the cubital tunnel for the ulnar nerve is called the Tinel sign or test. Palpate and do a rapid tap right over the median nerve. It is considered a positive finding if it reproduces the paresthesia or tingling, anything like that distally. If you suspect the patient has an ulnar nerve injury, you could perform the Froment sign test. Take a piece of paper and insert it between the patient's thumb and index finger with the hand resting on the small finger side as seen. Instruct the patient to hold the paper right against the rest of their hand and then you tell them, "Don't let me pull this paper out." An abnormal or positive finding is if the patient can't really hold the paper unless they compensate by flexing at the IP joint. The reason this would be indicative of an ulnar nerve problem is because the ulnar nerve innervates the adductor pollicis, and if it's not working, the patient will begin to compensate with the flexor pollicis longus. To assess for vascular integrity of the hand, you could perform the Allen test. Find the median and ulnar arteries and then instruct the patient to open and close their fist about 5 times. On the last squeeze, instruct the patient to keep it closed. Then compress both these arteries and then instruct the patient to relax their hand, opening it. Then you will let go of each artery one at a time. First, let go of the ulnar artery and look to see if blood fills the ulnar side. Then instruct the patient to repeat the same process, opening and closing their fist about 5 times. Now let go of the median artery, and you should see filling on the thumb side. A positive test would be distinct differences in filling time. When you compare sides, the color should return in about 3 to 5 seconds. What an incredible journey it has been. Thank you so much for watching.